considerations.
Thank you. Thank you, everybody, for your time and staying to the end. So I'm going to go over a few things with you. I think it's important to realize that there's a clinical aspect and an economic aspect for moving a practice to ASC. On the clinical side, you want to know that you're giving the same quality of care that you would otherwise. You want to have appropriate site of care selection. You need to understand what type of patients to take there and then which procedures to do over there. From an economic perspective, you want to look at the revenue, the volume of the other physicians who are there. Does the ASC have an employer program which will steer insurance companies over to you because you go to that facility, and that can even attract physicians, non-owners. We'll do the economic stuff last, but the question is, when you're first getting into practice and you want to go to an ASC, which cases are you experienced and efficient at performing? Take those cases. Which cases can you keep under 2 hours maximum? And what type of cases and patients are these? So there's some traditional things that we all know about, such as infection management with pre-op hemoglobin A1C, nutritional status optimization, looking at the BMI and total lymphocyte count, making sure they're not osteoporotic. And then, of course, preoperative narcotic optimization, because you won't get those patients out of the ASC if they have a lot of narcotics on board. Some of the scoring systems that are out there, one of them that we'll talk about is the Spine Surgery Invasive Index. Here's a study that they actually looked at the Spine Surgery Invasiveness Index and infection, and it was a regression analysis of 1,500 patients. And when they looked at the predictive factors, they're the typical things that we see: BMI, hypertension, the site of surgery. But the strongest predictive factor was the score on the SSII, greater than 21. So it does have some use to try to figure out who's the one who has a higher rate of infection. But what about the procedures? What procedures can you really take to an ASC? I'm just going to give you a couple of examples of each type of surgery, which I think is very reasonable to go in some papers. For example, with lumbar laminectomy, they looked at the NSCIP data for 30-day complication rates in 1 and 2 level outpatient versus inpatient. And other than the cost that you can see is less, the complication rates were definitely less with both 1 level and 2 level. And then when they looked at who were the ones who got the complications, it was, again, the more obese patients, the higher age, COPD and chronic steroid abuse, the higher class ASAs, and again, operative time of greater than 90 minutes. Similar stuff with ACDF, and I'm going to go over a couple papers with you. This is a retrospective review of a single ASC 30-day safety study. When you look at these 1 to 3 level cases, you can see that there was 2,000 cases, there was only 10 inpatient transfers. So that's a 0.5% inpatient transfer rate. And the 30-day all-cause readmission rate was 1.9%. So they can be done safely, even up to 3 levels. I don't send them home at 3 levels, but you can see there's literature here. There's another one, a retrospective review of 1,100 cases, inpatient again versus ASC, and this study even included 4-level cases. And when they looked at the cases that were done in the ASC versus the cases that were done in the hospital and stratified them by levels, it didn't make a difference. The complication rate was the same. And in fact, the hospital cost was a lot higher by approximately $6,000 than the ASC cost. So this is, I think, a more important study where they looked at 2,800 patients and tried to look at the risk factors for ACDFs in ASCs. And again, it's the same culprits: age, BMI, ASA, active dialysis, steroid use, taking more than 120 minutes. So if you can't do a 2-level ACDF in under 120 minutes, probably not best to take it until you get a little more proficient at it. Sepsis within 30 days, and of course, difficult airway. And I will tell you anecdotally, what I don't take to ASCs also is obese people who have truncal obesity, because they're going to have more of a difficult time with breathing postoperatively. What about laterals? Here's a study where they had 40 patients inpatient and 30 patients at ASC. It was a retrospective study with 2-year outcome data, and they found no difference in the VAS scores. The ASC patients actually got better ODI scores. The fusion rates were the same. All the complications they got were transient, and their surgical times were, interesting enough, shorter than expected. But when you look at the patients that they chose single level, no tumors, no deformities, no prior lumbar surgery. Their BMI was kind of a little bit higher maybe, and the most common level that they operated on was the easiest level, which is L3-4. So again, it's about patient selection. How about ALIFs? You can see here's a study on L5-S1 ALIFs where they did 58 of them outpatient and 79 inpatient. And when you look at the complications, none of the complications were vascular. The secondary interventions were for lack of adequate post-op pain relief. And the outcomes were very similar except for some improved, better leg pain and back VAS scores. ERAS protocols are very important. Please incorporate them if you're going to go there. Understand ESP blocks, QL blocks. Talk to your anesthesiologist. Make sure if they don't know how to do it, you know how to do it. There's a lot of papers about this. You can see the consensus statement that's up here that they have strong evidence even for intrathecal and epidural anesthesia. Here's 2 papers regarding long-acting liposomal bupivacaine, which Medicare is going to cover even in hospitals as long as the patient is outpatient as of 2025. There are papers that show increased discharge rate, lower stay, and cost savings, even though the medication costs about $500 per dose. But let's talk a little bit about the profitability models. There's different models out there that will for you to join an ASC. Some are 100% physician-owned, some are 100% hospital-owned, and then there's joint venture. And they each have their own advantages and disadvantages. It's about management, really, and, of course, about how much of the profits you'll take versus the management company. If you're looking at an ASC, you want to look at an ASC that has the right physician partners, high-volume guys who are bringing cases consistently, not just have shares and don't bring cases. I was a victim of that for many years. What kind of a management team do they have? What kind of experience does a management team have at running ASCs? Do they do pair contract negotiations? Do they hire competent staff? Do they have an implant program where you cannot bring in very expensive things that are not possibly necessary? Are they capable of creating efficiencies? And I would definitely talk to the anesthesiologist. If they don't have good anesthetists, I won't go there because that's a problem. You really need good anesthetists who are willing to manage the pre-op, the PACU, and even interview the patients ahead of time, review the cases. If they're not appropriate to be brought to an ASC, then they should call the patient, clarify it, and call you, say, hey, take this somewhere else. I'm just showing this cost data because of the next slide. You can obviously see that all this cost data for ASCs is a lot better than the hospitals. So the ASC should ideally have an employer program where they steer employers, the big employers in your community, to have the patients come to your facility because it's cheaper. They should be negotiating with insurance companies saying, hey, if you send your patient to Neil, and Neil works out of an ASC center, well, you're going to save money. So save them to Neil, save them to the guys who come to our ASC. That will get your ASC busier because non-surgeon owners will also be interested in coming there because they're getting patients sent to them because they go to that facility. Some of them will actually give them extra payment. But in order for your ASC to be able to do that, you have to have a robust outcomes data program. You have to be able to show the cost savings. You have to be able to show the quality. So if you have the right program, I think it's a win-win for everybody. Thank you.